Mark, what was the purpose of the study you embarked upon in the 2010-11 school year?
Well, Randy, really we had two purposes. One was to see how the medical students experienced caring for a dying patient. Because after all, they're going from being laypersons like you and I, to doing things like caring for patients and then caring for them at a very serious time in their life when they're dying. And we assumed that that must have a fairly profound impact on the students, and we wanted to hear in their own words what that meant to them. But also, we wanted to see their role models through their eyes. We wanted to see what they thought in terms of what was good practice in caring for a dying patient, particularly in terms of the interpersonal needs, the spiritual needs of those patients and their families. And also hear from them when they saw what they thought wasn't particularly good care of those patients or role models. So we wanted to learn from them about how people could care better for dying patients, and then also to know a little bit about the medical students themselves and their experience.
As background, is that the primary way medical students learn about caring for the dying is through the use of role models?
Yes, well, and medical education in general is very focused on role models. I mean, we have lectures and we talk to them about caring for dying patients, both in terms of their medical needs and then their interpersonal needs. But we do know that that most medical students really do most of their learning on the clinical rotations, seeing what they see from their mentors.
How did you go about assessing what they know and what they've learned?
Well, we asked them to write a reflection. We asked them to talk about a dying patient that they had cared for, and we gave them some prompts to ask them about what they saw that was good patient care, how the needs of the patients and their families were met, and then also what impact it had on their care of patients in the future. And they wrote us short essays on this topic, and then myself and several of my colleagues, that's a multi-authored study, analyzed these essays in terms of themes, and we pulled out particular themes from the essays that we saw repeatedly stated by the students.
And what were those themes? What did you see?
Well, on the patient care side, we learned a few things about their role models. There is some good news that while it's a mixed bag out there in terms of how we're doing caring for patients who are dying, the students reported many good role models. People who were fairly frank and able to break bad news to the patients and their families sensitively, because talking about death is always difficult, but people deserve the truth, deserve some frankness. And we heard that many physicians do quite well at that. They do well at relating to patients, that it didn't have to be a big, heavy thing all the time to care for patients, to talk about heavy themes like death, but that being able to relate to the person interpersonally, to be able to talk about their interests with them, to just show some interest in their humanity each day was very important. We heard that it was very important that physicians offer the use of chaplain services to patients and their families, that we can't expect physicians to be chaplains themselves and care for all the needs of patients, but that in fact just expressing that this service was available opened the door for families to talk about these needs, sometimes to ask the physicians and the medical students to even share a moment of silent prayer with them and those kinds of things. We also heard that there were some negative things about patient care. When you come to a big hospital like Loyola, there's many specialties, many people taking care of the patient. We sometimes say that care is a little bit fragmented in that you can be transferred from different services, surgery to medicine, to other kinds of services. People rotate on and off, the teams come and go over periods of time. And so that fragmentation of care means that if a physician or the team is not inclined to deal with patients' interpersonal or spiritual needs, they can kind of duck it. They could just keep treating the medical problems and somebody else then rotates on. And our medical students told us that that was a very unsatisfying experience for them, that they felt like they were not telling the truth just to the families and patients just because they were going about their business and not addressing the larger picture, and they felt they were cheating those families. Sometimes they expressed that things moved on a little too fast. A student would come in and the patient would have died overnight. And suddenly the patient was gone, the room was scrubbed and cleaned, a new patient was brought in, and they talked about a lack of closure, that this just didn't seem, it seemed inhuman to them to just go on without saying anything about it. However, some teams did pause for a moment of silent prayer or to process any thoughts that the team had. Obviously they can't take very long because they're very busy, but there were some real differences across the way the students reported some teams handled it versus others.
It seems that the first death that a medical student comes upon can be so impressionable. What did some of the students say that they would do differently the next time? What was the lesson learned?
Well, their reflections on what they would do in the future was very interesting. And the key theme that we kept hearing from them as they talked about this, though, was a struggle with desensitization. They felt like they had to hit the perfect amount of desensitization because, dealing with death is so emotional. One student related to us that, he was in an OB unit at the birth of a child, and it was meant to be a joyous moment, and the baby was stillborn. And suddenly, he starts crying. He said uncontrollably, and fortunately his resident took him out of the room and let him express his emotions and was very supportive of him. But he realized that while it's good to be sensitive and relate to people, that just takes the focus completely off the family at that moment who needs him. So they have to become desensitized a certain amount. But to become too desensitized is also problematic because then you fail to connect with the humanity of the patient and the family. You can ignore or miss cues about their spiritual needs or their needs to relate to them. And so that was the main theme we kept hearing from the student side, was about this desensitization. And as they battled that, some committed to ongoing reflection, to always reflecting on the death of a patient after the patient dies, because that's a unique individual and they don't want to become so desensitized they forget that and just move on, as I was talking about earlier.
Well, what are the implications of your research for medical education and bigger picture patient care in the future?
Oh, and we're just starting to unpack that. There's some low-hanging fruit, it seems, that we can think about. For instance, from this paper, we've started to think about instituting a spiritual timeout for a team. That when a patient dies, you simply call a timeout for a couple of minutes, and the team gathers and just is asked for a moment of silence, or if anybody would like to say anything. And at least there's some acknowledgement of that, and so perhaps that can help preserve some of this, help us hit that appropriate sensitization mark. But beyond that, it's trickier. How can we help people reinforce the good messages and eliminate the bad ones? Perhaps recognizing good role models would be helpful to us. Some students as we talked about, that fragmentation of care. Some students reported that they had attendings who would have them follow a patient who was dying once they moved on to another service, even though the patient's no longer on their service, have the med student go see how they're doing and report back so that everybody on the team gets the picture of what's happening to that patient. Perhaps when people reach across the fragmentation of care like that, we should recognize them. We should, they should get an award or be recognized that month as an outstanding clinician. So we have to keep finding creative ways to reinforce these good messages for the future.
Well, is there anything else you would like to add? Do you think this essay project will be continued?
I think so. I think that we have to also look at how other healthcare professionals view it besides med students. For instance, we did learn that our nurses are tremendous teachers of our med students during this period, and yet we really are always focused on the physician side. Yet our med students were reporting that it was the nurses who were bringing them up and helping them care for the patient's body after the patient died, and reinforcing some really important lessons. So extending the project to other professions is really important. But then again, looking just at creative interventions and assessing those interventions. We only want to do things if they're effective. We don't want to put things into place and not be sure that in fact they actually helped the situation.
Thank you for sharing what you learned.
Thank you, Randy.